So we continue our discussion about the penicillins, right? Mainly today we will be talking about the side effects related with the penicillins. But before we really start the side effects of the penicillin, I want to mention something that penicillins and aminoglycosides, if they are given together, right, their effects are, bactericidal effects are better. Why? Who can explain it to me? It's a very good combination for dangerous organisms that penicillins are given with, yes, plus aminoglycosides. Yes. Why this combination is good? Who is going to tell me? Yes, sir.
I think penicillin act on the cell wall. And it's more easier to aminoglycoside go to the.
Very good, excellent, doctor. You are right that if this is the bacterial inner bacterial cell membrane, right? And here is your bacterial cell wall. This is bacterial cell wall, peptidoglycan cross links, and there are special transporters in the bacterial cell membrane which are basically working to, this is aminoglycosides like gentacin, amikacin, yes, tobramycin, there's so many aminoglycosides. Now aminoglycosides are basically actively transported through these membrane transporters into the bacteria. And if penicillins are there, and if penicillins are damaging the cell wall, right, then what happens, that penetration of aminoglycoside up to the cell membrane become facilitated, right? So what really penicillins do, penicillins basically when damage the cell wall and make the cell wall very weak, then drugs like aminoglycoside, they can more easily reach to the bacterial cytoplasmic membrane from where they are more actively pumped into bacteria. In this way, aminoglycoside reach to their target site in the cytoplasm of bacteria more effectively, and their effects, bactericidal effects, become more. Is that right? So that is why penicillins can be combined and with aminoglycosides in more serious infections. But there is one thing, when you are combining penicillins and aminoglycoside, they should not be put together in one container. Why? Rather they why they should not be put into one container? Because penicillins are, penicillins are negatively charged, and aminoglycosides are, positively charged. Aminoglycosides are positively charged, right? Because penicillins are negatively charged and aminoglycosides are positively charged, so they should not be put into one container for a long time, because then aminoglycoside will complex with the penicillins, negatively charged penicillins, and make insoluble, non-effective complexes, right? After this little point, now we go to our main discussion of today, that is about the adverse effects of penicillins. Now, when we talk about the adverse effects of penicillins, let's suppose here is your circulatory system, right? Here is your immune headquarters. Immune system, immune headquarters. Here is bone marrow house. Bone marrow house. Here is your Yeah, what is it? It is GIT. Don't think of other things. Here is your GIT. And here is your beautiful, yes, what is it? Kidney. And of course, I believe you have central nervous system also. Now we will talk about side effects or unwanted actions or toxic effects of penicillins. Before we really talk about adverse effects of penicillin, you must know penicillins are one of the very safe drugs. They're very commonly used. They're one of the safest drugs, and they're so safe that their blood levels are not monitored. Is that right? We don't monitor their blood levels in the patients. What is the penicillin level? Is it going to be toxic or not? They're one of the very safe drugs, but still they have some important side effects. And one of the most important side effects are related with the immune system, right? And we call it hypersensitivity reactions. What are these reactions? Yes, hypersensitivity reactions related with penicillins. Now, how do you define hypersensitivity reaction? What is your concept of hypersensitivity reaction? Any immune reaction which is tissue damaging is called hypersensitivity reaction. Any immune reaction in your body which is damaging the tissue is called hypersensitivity reaction, right? Now, what type of hypersensitivity reactions are seen regarding penicillins? Okay. Dr. Carlos is saying that penicillin produce type 1 hypersensitivity reaction. Do you think penicillins can produce type 2 hypersensitivity reaction also and type 3 hypersensitivity reactions also? Or they produce only type 1 hypersensitivity reaction? Yes, Tito. Okay. Do penicillins produce only type 1 hypersensitivity reaction, or can they produce type 1 as well as in some other patient type 2, and still some other patient it can produce type 3 hypersensitivity reaction? Answer is yes. In different patients, penicillin may produce different types of hypersensitivity reaction. So penicillin, this is the very basic thing you must know about the penicillins, that they have the capability to produce type 1 hypersensitivity reaction, as well as they have a capability to produce type 2 hypersensitivity reaction, as well as in some other patient, penicillins may produce type 3 hypersensitivity reactions. As you know, type 1 hypersensitivity reaction is classically produced when against the antigen we produce IgE. What is that? In type 1 hypersensitivity reaction, this is also called immediate type hypersensitivity reaction. Sometimes what happens when penicillins enter into your body, right, some of the metabolites of the penicillin, the metabolite which most commonly produces penicillin hypersensitivity reaction is penicillinoic acid. Penicillinoic, what is that? That is penicilloic acid. This is one of the metabolite of penicillin. This metabolic breakdown of penicillin has a capability to bind with our proteins. It can bind with the human proteins. Alone, penicillin or its breakdown product are so small in molecular weight that alone penicillin or their metabolite cannot activate our immune system. It's very important. Penicillin or their metabolic products are so small in molecular weight that alone they cannot activate our immune system. But because some of the penicillin's metabolites are capable of reacting and making a complex with our proteins, and then after penicillin metabolite bind with the human proteins, then they, in some patients or some persons, they have a capability to activate the immune system. Is that right? It means penicillin molecules are like heptans. What are heptans? Heptans are the molecules which cannot activate immune system on their own, but they can activate immune system by complexing with our own proteins. Is that right? Now, when penicillin, right, activate our immune system, it can produce hypersensitivity reaction. Now, in some patient, it will produce type 1 hypersensitivity reaction, in which case, basically, Ig, what is happening? IgE is produced. IgE antibodies are produced against the penicillin or their metabolites, and these IgE are loaded on the mast cells and basophils, right? These are anti-penicillin IgE molecules which are attached with the mast cells and the basophils. Now in these patients, whenever penicillin molecule is introduced, that will activate the IgE molecules which are loaded on the mast cells, and mast cells will be activated, and naturally from the membranes of the mast cells membranes will be activated, and they will release prostaglandins and leukotrienes. Then granules of the mast cell will release, yes, histamine and proteases, proteolytic enzymes. We damage the proteins of the tissue, and granules also release neutrophil chemotactic factor, eosinophilic chemotactic factor, and on prolonged activation, even mast cells and basophils genetic material is activated, and that may produce interleukin 1 and tumor necrotic factor. So what we can say, those patients who develop type 1 hypersensitivity reaction against the penicillin, what's wrong with those patients? That those patients have made anti-penicillin IgE that is loaded on the mast cells and basophils, and when penicillin come across these IgE molecules, right, mast cells are activated and basophils are activated, and their membranes produce prostaglandins and leukotrienes, and their granules, cytoplasmic granules, release histamine, proteolytic enzymes, and different chemotactic factors, and even their genetic machinery of mast cells and basophil is activated to produce interleukin 1 and tumor necrotic factor, right? And all these things will, these different chemical mediators will act as, they will produce a type 1 hypersensitivity reaction. Is that right? Now the most dangerous type 1 hypersensitivity reaction, most dangerous type 1 hypersensitivity reaction seen with the penicillin is anaphylactic shock. What is that? Okay, let's remove this nasty thing from here. Anaphylactic shock. The very good thing about penicillin related anaphylactic shock is it is very rare. That's the only good thing about it. It's not very common, but still you have to be very careful as a doctor. Is that right? That some patients, even though very, very rarely, some people on introduction with the penicillins may undergo anaphylactic shock. But remember one thing, that usually when we are going to give penicillins parenterally, we make a skin testing, right? We inject a very small amount of penicillin related compound in the skin, and we see there is immediate type hypersensitivity reaction or not. Because if patient is having IgE loaded mast cells under the skin, as soon as you will inject the penicillin, within few minutes there will be some redness and swelling, right, in that area, and of course to those patients you will not give penicillins. And this type of reaction is immediate type because it appears within few minutes. Is that right? Patient is prior sensitized to penicillins. So classical example of this is anaphylactic shock, or most dangerous type 1 hypersensitivity reaction related with the penicillin is anaphylactic shock, in which mast cells around the blood vessels are activated, and blood vessels dilate and blood pressure dangerously drop. Mast cells around the bronchial system is activated and bronchoconstriction occur. Mast cells in the GIT are activated and abdominal pain develop. Mast cells under the skin are activated and you develop rashes. So of course this is the most dangerous side effect related with the penicillin. Is that right? Then there are some other side effects related with the penicillin. Let's talk about the type 2 hypersensitivity reaction. A classical example of, first of all, you must know what is type 2 hypersensitivity reaction. Type 2 hypersensitivity reactions are those reactions in which immune system is activated against the antigens which are intrinsically present in the cell membranes and other tissue membranes. Again, what happens, let me explain exactly how it happens. Let's suppose this is a red blood cell. The red blood cell. These are red blood cell, what is this? Antigens, which are normal RBC antigens on RBC membrane. Now, if a penicillin metabolite bind here, with these normal proteins, these normal proteins are altered. In some patients what happens, the penicillin metabolite bind with our normal proteins, for example in cell membrane proteins, and alter these cell membrane proteins. When these cell membrane proteins are altered, they are no more recognized as self protein. Our immune system failed to recognize these penicillin mediated altered RBC membrane protein as self protein. Right? Immune system sense them as foreign, and immune system may make antibodies against that. And if immune system is making antibodies against these altered proteins which are the part of the cell membrane, then of course antibodies will bind with these RBC membrane. Usually these are IgG, and then they may activate the complement and break down the RBC. Or these antibodies which are binding with the RBC membrane, they act as opsonin. On one side they bind with the RBC, on other side the Fc portion of these antibodies bind with macrophages and neutrophil and enhance the phagocytosis of RBCs, facilitate the hemolysis of RBCs. You are understanding? So this is what? Penicillin associated autoimmune hemolytic anemia. So in some patients, penicillin or some other drugs can produce hemolytic anemia. Now this hemolytic anemia is not IgE mediated, and it is not mediated, it does not involve the mast cell. So it is not type 1 hypersensitivity reaction. This type of reactions are called type 2 hypersensitivity reaction. So what did we learn? What did we learn? That some patients may develop IgE against the mast, against the penicillin, and patient become vulnerable to develop type 1 hypersensitivity reaction or immediate type hypersensitivity reaction against the penicillin. But some other patients, right, they in that case penicillin metabolite alter some of our cell membrane proteins, and then immune system make antibodies specifically directed against that particular cell membrane proteins, and that specific tissue is altered, and that is called type 2 hypersensitivity reaction, which does not involve IgE, which does not involve mast cells and basophil. And type 2 hypersensitivity reaction of this classical example is penicillin associated hemolytic anemia, right? Immune mediated hemolytic anemia, is that right? Then there's type 3 hypersensitivity also. Can you give me some example of type 3 hypersensitivity reaction? A patient who is given penicillin and he developed type 3 hypersensitivity reaction. Yes, doctor? I don't like to share your knowledge. Yes?
Kidney nephritis, when you have
okay. Yes. The classical example of type 3 hypersensitivity reaction is that in your body fluids and blood, there are antigen antibody complexes circulating. We say they are immune mediated reactions. What really happens is that in some patients, penicillin or their metabolites are circulating for a long time, and immune system make antibodies against the penicillin molecules or against their metabolites, and these antibodies, anti-penicillin metabolites antibodies, make complexes within the circulation. So what happens? Sometimes what happens that against the penicillin molecule, IgG or IgM is produced, or against the penicillin metabolites, IgG or IgM is produced, and these IgG, IgM bind with the penicillin or penicillin metabolites in circulation, right? And then in this way, in the circulation, immune complexes are formed. These immune complexes may get deposited in multiple areas. As these immune complexes are circulating, they may get deposited in multiple areas. Number one, these immune complexes may get deposited, right, in blood vessels. In blood vessels at multiple area, when these immune complexes are deposited, they activate the complement, and complement may activate the neutrophil, right? So wherever immune complexes are deposited in blood vessels, complement mediated and neutrophil mediated damage will occur to that part of the vessel. So we say in type 3 hypersensitivity reaction, the very special damage is vasculitis, inflammation of the vessels. So there will be evidence of vasculitis, vasculitic lesion, vasculitis, right? So now classically there's different types of vasculitis. how they clinically manifest in many different ways. When immune complexes are deposited in the blood vessels under the skin, the multiple vasculitic lesions under the skin, the small blood vessels under the skin undergo inflammatory damage and you develop multiple small rashes. So there may be rashes. Vasculitis may lead to, yes, skin rashes. Then if immune complexes get deposited in glomerular structures and activate complement and neutrophil there, that may produce glomerulonephritis, which will clinically present as proteinuria and even hematuria. Is that right? Then if these immune complexes get deposited in synovial membranes, that may produce polyarthritis. Polyarthritis. If these immune complexes get deposited, yes, in pericardial membrane or pleural membrane, that may produce pericarditis or pleuritis. Pericarditis or pleuritic inflammation, pleuritis, right? And if these immune complexes, many of these are trapped into lymph node, you develop generalized lymphadenopathy, right? And of course, when there are so many immune complexes, circulating immune complexes getting deposited under the skin, deposited in glomeruli, depositing in the synovial membrane, depositing in pericardium or pleura. So all these areas, complements and neutrophils and macrophages are activated, and these inflammatory cells may produce interleukin 1 and tumor necrotic factor, which may act on hypothalamus, and patient may develop fever. And along with the fever, patient may develop malaise. Is that right? So this type of reaction, all these reactions are called type 3 hypersensitivity reaction. Type 3 hypersensitivity reaction occurs usually after the injection of penicillin. They don't occur immediately, remember. Type 1 hypersensitivity reaction develop immediately, but type 3 hypersensitivity reaction develop after many days, sometimes 7 to 12 days after injecting penicillins, right? So again, if someone is given penicillin and immediately his blood pressure starts dropping and immediately rashes develop within few minutes, and bronchoconstriction, difficulty in breathing, dyspnea, it is type 1. And if someone has been given penicillin and after that he develops autoimmune hemolysis, this is type 2. And if someone has been given penicillin, let us suppose injection of procaine penicillin, and after 7-8 days he develops multiple rashes with polyarthritis and glomerulonephritis with proteinuria and hematuria and chest pain due to pericarditis or pleuritis and generalized lymphadenopathy with fever, malaise and anorexia. This is an example of which type of reaction? Type 3. Type 3 reaction may also produce angioedema. What is angioedema? This is an example in which patient may develop after getting penicillin, after a few days, patient may develop severe swelling of the lips. Patient develops his own lip swelling. Swelling of the lips, swelling of the tongue, and periorbital swelling, right? We call this condition angioedema, right? So these are different types of allergic reactions which may be seen with the penicillins. Usually 5 to 10% people who are given penicillin may complain about different type of penicillin reactions, but again, it's worth remembering the most dangerous hypersensitivity reaction related with the penicillin is anaphylactic shock, and thank God it is the most rare one. Am I clear? Any question after this? No. Then a very special mention of ampicillin related maculopapular rashes. Doctor, you have heard about it? That people who are given ampicillin after some time they may develop maculopapular rash all over the body. That is called ampicillin associated maculopapular rash. The point which I want to tell you, the most of the ampicillin associated maculopapular rash, macules and papules, are not hypersensitivity reaction. They are not IgE mediated, right? That is direct toxic damage of ampicillin in skin. Why it is so important to know? It is so important to know because if someone has a history of ampicillin related, for example, you give the ampicillin to someone and he develops after a few days ampicillin related maculopapular rash, if you know that that is not hypersensitivity, that is simple toxic reaction, you can continue ampicillin and after a few days they will disappear. But if any reaction occur severe hypersensitivity like type 1 hypersensitivity or type 3, of course you have to immediately stop the drug. Is that right? So you have to remember that most of the ampicillin related maculopapular skin rashes are not hypersensitivity in nature, they are simple toxic reactions. Am I clear? Another situation. There is, okay, I'm going to make a diagram here. This is a person and here is another person, right? I hope you understand what's going on. What's going on? You have general knowledge, okay. I'm impressed. Now, some people's, there is a special viral infection. If you are having that viral infection, okay, I will give you a more simple example. There is a special type of viral infection. If you get 100 people with that viral infection in this town, if you get 100 people in your hospital with that specific viral infection and give everyone ampicillin, everyone will develop maculopapular rash. What is that virus? This is very important. There is a viral infection and if you give ampicillin in the presence of that viral infection, the development of maculopapular rash, of course in the skin, goes up to 100% cases. And this diagram should remind you of that virus. No. What they are doing? They are kissing. Yeah, look at their, wow. Now, do you thought their hands? Oh my God. Thank God you didn't think it's something else. Okay. Now it's okay? Hands are down, so it's clear. What is the viral infection which spreads by the kissing? And if you have that viral infection and you give ampicillin, right, there's 100% chances patient will develop maculopapular rash. Epstein-Barr virus. I knew Carlos knows about that virus. Epstein-Barr virus, which spreads by the saliva, right? In young adults, it's very common. And Epstein-Barr virus, when spread from one person to the other person, what type of disease it commonly produces? Infectious mononucleosis. Have you heard of infectious mononucleosis? The organism related with that is Epstein-Barr virus. So any patient who has infectious mononucleosis, if you give the ampicillin injection, 100% chances, almost 100% chances, he will develop maculopapular rash. And these rashes are not hypersensitivity reactions. Am I clear?
So it's very common because cytomegalovirus and EBV, 90% of the population have it.
Epstein-Barr virus is,
70% of the population.
look, I say when this virus is producing infectious mononucleosis. When you are suffering with infectious mononucleosis and due to any reason you are given ampicillin, chances are almost 100% to develop maculopapular rash all over the body. Claro? Okay. Now, few more points related with this. Any question you want to ask about penicillin hypersensitivity reactions? No? Okay. Let's just...
if a person has a sensibility for penicillin, I can use cephalosporins.
Okay, this is a very intelligent question. He is asking that if a person has what? Allergy to penicillin, hypersensitivity to penicillin, can we use cephalosporin? Answer is, a good doctor will first know what kind of reaction is there. If you are having penicillin associated IgE mediated reaction, it's better to avoid cephalosporin. If patient is having penicillin associated IgE immediate type reactions, of course, if it is anaphylactic shock, history of anaphylactic shock with the penicillin, you don't give cephalosporin because there is some partial cross allergy between the penicillin and cephalosporins. If you have 100 patient with penicillin allergy, about 5 to 10% of them will be also allergic to cephalosporins, right? But again, it's very important to remember that if someone have type 2 or type 3 hypersensitivity reaction to penicillin, right, it's not a big deal. You can give cephalosporin if it is must. But if someone has history of type 1 hypersensitivity reaction with penicillin, it's better not to try cephalosporin and look for alternative drug. Am I clear? So that is why it's very important to know that the person who is having allergy to penicillin, what kind of allergy is there. And how do you determine that immediate type penicillin sensitivity is there or not? By skin injection. When you give test dose under the skin, patient develop within few minutes reaction to penicillin. It means that he is having type 1 hypersensitivity reaction. And then of course, it's better to avoid cephalosporin. Am I clear? Right? But if there are some other type of penicillin allergy and you need to give cephalosporins, you can. What could be such situation? For example, when someone is suffering with the staphylococcal aureus infection, and that staphylococcus aureus which is producing beta lactamases. Beta lactamases of staphylococcus aureus can break down the beta lactam ring of penicillin, but cannot break down the beta lactam ring of cephalosporin, right? So in those conditions where penicillin G is destroyed by staphylococcus related beta lactamases, you can give first generation cephalosporin. Am I clear? Okay. Then we go to the another side effect related with the penicillin. Another type of side effect is that when penicillins can produce, especially that side effect is more common with ampicillin, right? That some penicillin, especially extended spectrum penicillins in heavy doses for prolonged use can produce diarrhea. They can produce diarrhea. Why extended spectrum penicillin can produce diarrhea? Especially ampicillin. Yes, my friend. Because let's suppose you are giving your patient orally. You have two patients. In one patient you are giving orally amoxicillin. In other patient you are giving orally ampicillin. Which has more chances to produce diarrhea? Ampicillin or amoxicillin? Ampicillin. The reason being, when you are giving ampicillin, ampicillin is poorly absorbed from GIT. So it stays in GIT for a longer time, goes to the distal part of the GIT and disturbs GIT normal flora. But amoxicillin very effectively absorbed from GIT to the blood. So it does not stay in longer duration and higher concentration, does not disrupt the GIT flora significantly. Are you understanding it? So what happened? Ampicillin, right, especially when it is given orally, right, it stays in GIT in high concentration, as from GIT it is poorly absorbed. If you want to give penicillin for some systemic infection, you should give it parenterally. So ampicillin will disrupt the GIT flora, kill many gram-negative bacteria in the GIT, and give a chance for, yes, what? Resistant bacteria to overgrow. For example, Clostridium difficile. And when other bacteria overgrow, they may produce diarrhea. Are you understanding it? See, though you don't understand it. Look, in the GIT, there are many bacteria. You are so rich in bacteria and GIT that in 1 gram of your fecal matter, the number of bacteria may be more than the number of human beings on earth. You are rich, right, as far as bacteria are concerned. Now, there's so many bacteria there, but usually we are not sick by those bacteria because all these bacteria are competing for the food, and most of them are not pathogenic, and some of the bacteria in the GIT may be pathogenic, but under normal circumstances, the non-pathogenic bacteria are in such a big number, they don't allow the pathogenic bacteria to proliferate enough and produce disease. Are you understanding this theory? Whenever we are using broad spectrum antibiotics, especially in high concentration and for a long time, then many of the normal bacteria in GIT are killed. And if there are resistant bacteria which are pathogenic, they are not killed by broad spectrum antibiotic, they will overgrow because their competing normal flora is eliminated by broad spectrum antibiotic. When they will overgrow, their concentration will become high and they will be able to damage our GIT and produce diarrhea. Sometimes they damage the GIT so severely that they produce a condition called pseudomembranous colitis. What is the condition called? Pseudomembranous colitis. Ampicillin can produce this. Pseudomembranous colitis, what happens? That normal flora of the GIT is killed and pathogenic bacteria overgrow, especially Clostridium difficile. That overgrows and that damages the GIT mucosa a lot and produces severe inflammation in GIT mucosa and produces bloody diarrhea. Is that right? Am I clear? So this is one more side effect of all broad spectrum antibiotics, including extended spectrum penicillins. Clear? Then another group of side effect, yes, what is it? Nephritis. In the kidney, some of the penicillin can produce nephritis, inflammation of the kidney. The most notorious regarding nephritis is methicillin. What is that? Methicillin. Methicillin and Nephicillin can also produce nephritis, Nephicillin, but less often. Methicillin is very notorious to produce severe nephritis. It was rather, I must say, so notorious that now in USA they have removed all the product. Methicillin is no more available. Methicillin is no more available for human use because it was producing very high incidence of inflammation in the kidney, damage to the kidney and nephritis, right? But some of the other penicillin like Nephicillin less often can produce nephritis, right? Then neurotoxicity. Penicillin and their metabolites, if in high concentration reach to the central nervous system, they irritate the neurons. Penicillin and their product can irritate the neurons. You will be surprised that if this is a neuron and this is some cationic channel, suppose calcium channel or sodium channel, penicillin and their metabolites can disrupt their function. A lot of cations are loaded in the neurons. If a lot of sodium or calcium go into neurons get overstimulated. So they are irritatory, excitatory to the penicillins in very high concentration. If they reach to the central nervous system, they can irritate the neurons and even they can precipitate seizures, especially in the patient who have tendency of epilepsy. That is why we avoid giving penicillins intrathecally. Intrathecally means we don't give penicillin in subarachnoid stage, subarachnoid space. Secondly, if penicillins are given in those patients who have renal failure, you know, main route of most of the penicillins are eliminated from kidney, and if there is a renal functional impairment, then penicillin may accumulate in the blood, and they may, if they can cross blood-brain barrier, they may accumulate in such a high toxic concentration in central nervous system, they may precipitate seizures. Is that right? Then some hematological toxicity. Bone marrow house. One of the very important toxicity related here is platelet dysfunction. Platelet dysfunction. Some of the penicillins can bind with the platelets and alter the platelet surface receptors. And if platelet surface receptors are altered, the capability of platelet to aggregate is reduced. So some of the penicillin can disrupt the functional aspect of the platelet membrane and reduce what? Aggregation of platelets and produce bleeding tendency, right? Especially those penicillins which are with the James Bond. You remember which were the James Bond penicillins? Carbapenem and Ticarcillin. So you can remember car can hit the platelets as well as tick can bite the platelets, right? So Ticarcillin and Carbapenems, which are well-known anti-pseudomonal penicillins, right? They can damage the what? Platelets membrane, and then there's a tendency for bleeding. Moreover, penicillin can also produce neutropenia. One of the mechanisms may be when neutrophils are surface proteins of the neutrophils are altered. Surface proteins of the neutrophils are altered, and if anti-penicillin antibodies react with the altered proteins of the neutrophils or granulocyte precursor cells, the cells in the bone marrow which produce neutrophils, if they are hit by the immune reaction, you will develop neutropenia. Are you understanding me? Right? Then we can come to cation toxicity, the last side effect, right? Last side effect is cation toxicity. Most of the time, penicillins are given as salt of sodium or potassium. Penicillins are given as salt of sodium or potassium. If penicillins are given injected as salt of sodium and penicillin therapy is in high concentration for many days, so much sodium is loaded, sodium is positively charged, so much cations are loaded that sodium may hold the water and dilute the potassium in the blood, and dilutional hypokalemia may occur, right? That in these cases, of course, you should use those penicillins which are highly potent, because penicillins which are highly potent, they need to be given in small doses. So cation toxicity will not develop, and especially penicillin when you are using in the patient with severe intractable congestive cardiac failure. You have to use the penicillin which are highly potent, because if you use less potent penicillin with a lot of cation load, that is not good for the patient's hemodynamic aspects. Am I clear? Do you have any question about the penicillin side effects? Yes, please.
Yeah, what about use of ampicillin and complex, B complex? Because they change the natural flow of the GI tract.
Yeah, look, no, it can be good, but again, you are talking about this, that whenever we use broad spectrum antibiotic, many microbes in the GIT are killed, and many of the microbes in the GIT are responsible to give us a good supply of B12. So usually whenever we give broad spectrum antibiotic, especially long time, it's very wise to give B12 complex with them, so that as GIT microbes are eliminated, right, then B12 deficiency should not develop. Is that right? But that can be a good combination. That is not an issue with that. Any more question? No question? Class dismissed.